in the interest of time and the fact that no one is here to hear me talk, my name is Scott Canna. I'm a pediatric rheumatologist at Children's Hospital in Philadelphia. I'm here, I suppose, representing the Histiocyte Society's HLH steering committee, and really excited to do this. Is our second uh, sort of combined webinar with the Clinical Immunology Society, working on the intersection of HLH and immune dysregulation, and in particular in trisomy 21. So thanks everybody for joining. And I'm going to turn it over to Joel Lopez of the CIS.
Thank you, Scott. And we already have a lot of chat messages confirming they're here, so you were talking to a large audience. Don't fear. So my name is JP Lopez. I'm one of the co-chairs of the Early Career Immunology Committee for the Clinical Immunology Society for CIS. It's also a pleasure to host the combined webinar with Histiocyte Society. Before we go in with our excellent talks, I just wanted to put you in a plug for the new Journal of Human Immunity. We'll stop calling it new at some point because it's been now establishing itself. But just to remind you that the Journal of Human Immunity is welcoming submissions of papers in your research and all of that. So keep all of that in mind as you're talking through or thinking through your submissions of your research and all your work. So without further ado, we'll move into our first speaker today, who is Dr. Jonathan Lee, a pediatric rheumatology fellow at UPMC in Pittsburgh, Pennsylvania, who's going to be talking to us about a trifecta of HLH contributors in a patient with trisomy 21. Jonathan?
Hey everyone, thank you for giving me the opportunity to present this case, and thank you to Dr. Scott Canna and Katie Paul for mentoring me and preparing this presentation and taking care of this patient initially and allowing me to get these slides together to share with everyone. So we'll get into the case. 5-month-old girl with trisomy 21. She was born full term. Shortly after birth, she was found to have a VSD and a duodenal atresia, which was repaired. And then she now presents after 1 week of fever, fussiness, and rash. The rash is non-pruritic, macular, it's erythematous, it's on her arms and legs. Initially seen by the PCP, thought it was just a reaction from having sensitive skin. The rash kind of got better on its own over the next 3 days. This is how the rash looks. Okay. And then shortly after that, she started to develop fevers that were up to 101, 102 Fahrenheit. Initially, they were just here and there, and then it started to become daily, and then it started to become just persistent throughout the day. She had become increasingly more fussy and was not feeding well, so parents brought her to the emergency department. Her presenting vitals, she had a fever, she was tachycardic to 136, her pressure was 98/65, she was breathing at a rate of 32 and 96% in room air. The exam is notable for just fussiness in the rash, but otherwise nothing else that was remarkable. They did an initial workup. Her CBC had an elevated white count of 20.5 with a neutrophil predominance. Her hemoglobin was 10. Her platelets were elevated at 403. CMP was notable for normal electrolytes, normal renal function. Her albumin was low at 2.7 with a normal total protein. She had an elevation in her liver enzymes with an AST of 112 and an ALT of 275. Her SED rate was 87. Her CRP was 15.7. Our cutoff here is less than 0.3. Her flu RSV swab was negative. This was pre-COVID days, the good old days. UA was normal. They got a chest x-ray and an abdominal film, which were normal as well. And they also did a full body scan, which was also normal. So she was admitted for further stabilization and workup. She was empirically started on ceftriaxone. She had a full viral panel, respiratory viral panel that was negative. She had adenovirus, EBV, CMV PCRs, and HHV6 PCRs that were sent in negative. She had met criteria for Kawasaki disease, and so had an echocardiogram obtained, which was normal, and then was given an empiric course of treatment of IVIG, which did not help, and she remained intermittently febrile. It was at this point that rheumatology was consulted, and some labs were sent to evaluate for a hyperinflammatory state, such as HLH-MAS. Her ferritin returned at 25,000, and she was started on anakinra. She did great at first, defervescing to once daily anakinra, but then despite that, her labs got worse, and so prednisone was then added. And then, so cytokines were also sent, and shortly after steroids were added, they trickled back. Her IL-18 was elevated at 261,000, her CXCL9 at about 31,000, and her soluble IL-2 receptor was 8,000. So further workup was sent due to concern for primary HLH, including rapid whole exome, functional testing, and a bone marrow biopsy was obtained as well. So these are the results of her perforin granzyme testing. So she had normal function, normal expression of perforin. Her CD107A mobilization was also normal. Her rapid whole exome returned. So apart from the trisomy 21, a mutation in the HFE gene was identified, which is associated with hereditary hemochromatosis, but she didn't really have any features of that at this time. And she had a heterozygous PRF1 mutation, which had previously been reported and was associated with decreased expression and cytotoxicity, but her testing, as we just saw, was normal. And then her bone marrow biopsy returned showing features of hemophagocytosis. So given these findings, she was initiated on the HLH94 treatment protocol with dexamethasone and etoposide. And she had a very good response. So as you can see, all of her labs generally improved. And so just to orient you to this graph quickly, the y-axis is log of fold change from normal. So her IL-18 was almost 3 times upper limit normal and essentially normalized after receiving treatment. She did well for a couple of months, and then she had a flare that was triggered by adenovirus, and so again had an HLH-like presentation with an increase in her IL-18 and her ferritin. So she was treated with a short course of emapalumab, which helped normalize her labs and her clinical presentation. And then she was transitioned over to canakinumab for more long-term maintenance. She did well for a long time with the canakinumab, but then we'll get into what happens next. So she's on the canakinumab, and so for a patient like this who's now had 2 episodes of HLH that has responded to HLH-directed therapy, and also has trisomy 21, hyper IL-18 elevation, a known pathogenic PRF1 mutation, but with normal protein expression and function. Is this a patient that would be a candidate for transplant for kind of long-term correction of these deficiencies in her risk for HLH? And just to kind of, as a thought-provoking question, what are the challenges for stem cell transplant in a patient with trisomy 21? So just some food for thought. So just moving on through the rest of her clinical course, she did very well on canakinumab for a while, and then she started to develop an asymptomatic transaminitis. Her IL-18 was rising, but clinically was doing okay. But due to these changes in her labs, without actually going into HLH, the decision was made to transition her to a JAK inhibitor, which she did really well on, actually. And as you can see, when she was switched, her IL-18 started to come down and improve. So since switching to TOFA, she's been doing really well. Her IL-18 normalized. We're now 5.5 years out from her initial presentation and 4 years out from sustained remission. We attempted to wean off her TOFA, and she did well for about 9 months without any immunosuppression or modulation. But then she had a pneumonia and again triggered a small flare with recurrence of rash, which is pictured to the right. She was restarted on TOFA, and over the next 3 months, her labs slowly improved again. And so she's been doing well over the past 8 months on TOFA monotherapy. Her most recent labs were mostly normal. And, you know, uh, even though this recent episode was triggered by pneumonia, she has done well with flu and COVID, but presumably has not yet seen EBV, which we know is a major HLH trigger. So question mark as to whether that will be an issue in the future for her. So just to kind of tie things together and to lead into our main talk. So here we have our patient in cytokine storm with multiple contributing factors, including specific viral infections, trisomy 21, possible interferonopathy, IL-18opathy, a perforin 1 mutation, and a hemochromatosis risk allele. So how do these factors all play together in terms of this patient's risk for HLH in the future, and how does it help inform our treatment and management? Does it inform use of JAK earlier, or what is the role in JAK in general for treating patients with trisomy 21 versus classic systemic JAA?
Thank you, Jonathan. Great case and great talk for sure. So I know you guys have a lot of questions. I put it in a chat, but we will try to go through both talks and then we can try to address those together. So I'm going to introduce the pleasure for us to have Dr. Joaquin Espinoza, who is a professor in the Department of Pharmacology at the University of Colorado, the Anna and John C. Chair in Genomics and director of the Functional Genomics Facility and executive director of the Linda Cernstich Institute for Down Syndrome. And he's going to be talking to us about immune dysregulation in Down syndrome, mechanisms and therapeutic applications. That aligns really well with the case we just started. Thank you, Dr. Espinoza.
Thank you, Joao, and Katie and Scott and others for the invitation. It's a pleasure to present some of our research here to this esteemed audience. My name is Joaquin Espinoza. I work for people with Down syndrome. I run what is the largest center for Down syndrome research in the world, home at the University of Colorado Anschutz. And today I'd like to tell you more about immune dysregulation in Down syndrome. I'd like to start by celebrating with you people with Down syndrome, a diverse population surpassing all expectations. There are more persons alive with Down syndrome today than ever before. They are living longer than ever before. And I hope you will agree with me that they are also defying outdated notions about what is possible when living with an extra chromosome, as illustrated by these images here. Well, the point I want to make is that Down syndrome is not a rare disease. The rate of births, at least in the USA, has not declined, and the life expectancy has increased significantly from 20s or so back in the mid-20th century. Today, a baby with Down syndrome is expected to live into her 60s or so. So we have a new phenomenon in the universe. Adults with Down syndrome, hundreds of thousands, perhaps millions of them. Simply put, people with Down syndrome are here to stay. Now, we've known what causes Down syndrome since the late 50s. This French group by Lugen and colleagues found that people with Down syndrome have an extra copy of chromosome 21 or trisomy 21. And this was one of the first chromosomes to be sequenced during the Human Genome Project, leading to the identification of about 225 genes. There are no mutations per se, simply 1.5-fold gene overexpression. the question for us then, how does the extra copy of chromosome 21 causes the various clinical and developmental hallmarks of Down syndrome? Now that we have thousands of adults with Down syndrome, we can do proper epidemiology, and it has become very evident that people with Down syndrome have a differential clinical risk profile. On one hand, the extra chromosome is protecting them from some of the major killers of the general population. It's very rare to hear of an adult woman with Down syndrome having breast cancer, an adult man having prostate cancer, even after age adjustment. They're also protected from myocardial infarction, hypertension. But on the other hand, they're highly predisposed to Alzheimer's disease. The amyloid precursor protein gene is encoded on chromosome 21. They have more amyloidosis, early pathology. They have a ton of autoimmunity. We'll talk about that more in a minute. Lots of complications from lung infections, vision and hearing impairments, and many other co-occurring conditions. So clearly, in order to serve people with Down syndrome, we need to understand how the chromosome causes this increased risk of various medical conditions. With this in mind, over the past 10 years or so, at the Cernic Institute, we've been running the largest cohort study of people with Down syndrome today, known as the Human Trisom Project, with all the latest technologies, deep clinical data, multidimensional biobank, panomics data sets. We have more than 1,600 participants recruited since 2016. From those biospecimens, we have generated large amounts of omics data. All the data eventually is shared with the public through the Include data hub. Many projects have been supported by this cohort, many publications, funded by multiple NIH institutes. And this multidimensional biobank has allowed us to take a fresh look, to use our beginner's mind to understand what the trisomy is doing on the transcriptome, the proteome, the metabolome, the immune cell repertoire, the microbiome, so on and so forth. We're strong believers in the power of these multidimensional biobanks to drive collaborative discoveries. So today I'd like to share with you one of the discoveries out of the Human Trisom Project that was rapidly translated into a series of clinical trials. The first publication came out in 2016. The first trial started in 2020, ended last year. A second trial started, is about to end, and now we're thinking about the third and the fourth trial designs, all of it supported by grants from the NIH Institutes via the Include project. So here's a key observation. This has now been reproduced in multiple cohorts. People with Down syndrome display widespread autoimmunity. By the time they're adults, more than 75% of them have been diagnosed with at least one autoimmune condition, the most common being autoimmune thyroid disease. Usually shows up as hypothyroidism, sometimes can be hyperthyroidism. Something that became very obvious in the last 5 years or so, they have a ton of skin issues: alopecia areata, atopic dermatitis, hidradenitis suppurativa, psoriasis, vitiligo, all T-cell driven autoinflammatory autoimmune skin conditions. They have 10 times more celiac disease than the general population, 10% probably an underestimate. They also have more type 1 diabetes, a form of arthropathy, not quite canonical rheumatoid arthritis, but an inflammatory joint disease, no doubt. Now, 80% of these autoimmune conditions are diagnosed during pediatric age. So we like to say that Down syndrome is a multi-organ autoimmunity of pediatric onset syndrome. This pie chart shall show you that there's a lot of co-occurrence, and for example, 75 have at least one, but 24% have two, 10% have three. You tend to see a lot of kids with Down syndrome having multiple autoimmune conditions at once. And this, of course, is just the tip of the iceberg. It makes you wonder what else in the constellation of symptoms of Down syndrome could be understood as an immune phenomena. So that first publication that I mentioned came out in 2016. We were looking at cell lines, primary samples, doing a few omics, transcriptome, proteome, shRNA screens, and in every experiment, in every cell type, very strong signatures of activation of the interferon response. Of course, you know what this is. This is our antiviral defense, type 1, type 2, type 3 interferon through various receptors. And we know, of course, too much of a good thing, in this case, interferon, could be a risk factor for autoimmunity and other phenomena. So why do people with Down syndrome have more interferon signaling? One key, most likely reason, I would say perhaps not all of it, but most of it could be driven by the fact that 4 of the 6 interferon receptors are encoded on chromosome 21. Let me remind you there are 3 types of interferon signaling, 1, 2, 3, different ligands, different dimeric receptors. The 2 type 1 receptors expressed in every nucleated cell in the body are encoded on chromosome 21, and 1 each of the type 2 and type 3 receptors also on chromosome 21. So if you have trisomy 21, you have more receptors, have an elevated interferon response. That would lead to elevated JAK-STAT signaling, overexpression of interferon-stimulated genes, chronic immune activation, and perhaps contribute to clinical and developmental hallmarks of Down syndrome. So let me show you some data. This is a massive transcriptome study, whole blood on a PAX gene RNA tube, 304 individuals with trisomy 21 versus 96 controls, and the volcano plot confirms that the French group, Blue et al., were correct. Genes on chromosome 21, shown in green here, are to the right of the midline, overexpressed about 1.5-fold. But you also see hundreds of other mRNAs dysregulated up or down in Down syndrome. When you feed that into a computer trained to detect signaling pathways, the top signature is a strong activation of the interferon gamma response, then a number 3 interferon alpha response, and if you look down the list, most of your favorite pro-inflammatory signaling pathways. Let me show you a little bit of the actual data here. Again, in gray, the 96 controls, in green, the 304 individuals with Down syndrome. The interferon receptors encoded on chromosome 21 obviously elevated, but then dozens of interferon-stimulated genes encoded elsewhere in the genome also significantly elevated. And like everything in Down syndrome, there's always a range, strong inter-individual variability. So we can, of course, calculate interferon scores. Let me, in response to one of the questions in the chat, the interferonopathy of Down syndrome is of a mixed type. These ISGs are type 1, type 2, and type 3 interferon signaling. So if you collect the top 16 elevated ISGs and calculate interferon score, as you would do, say, in lupus, this is what you get. 13-fold increase in the mean value with a lot of inter-individual variability. Some of them have 50 times, greater elevation of these interferon scores. To put this into scale, into perspective, we're running here the exact same interferon score, the same 16 ISGs or so, in individuals in the general population without and with SARS-CoV-2. This is in the early days of the pandemic. These individuals were hospitalized with COVID-19. Look at the scales. There's a massive amount of autoinflammation that we see in individuals with Down syndrome. We follow this up with a plasma proteomic studies using the SomaScan platform. Now we've done it with many other platforms, and the title of this paper says it all. Chronic autoinflammation. The blood of a person with Down syndrome looks like a mix of blood of somebody with rheumatoid arthritis, a type 1 interferonopathy, HLH, and you name it. You get those proteomic changes fitted to the computer. Once again, now proteins, not RNAs. Number 1, interferon gamma response. The number 4, interferon alpha response. You go down the list, a lot of pro-inflammatory signaling, very large sample size. Here's an example, beta-2M, beta-2 microglobulin, subunit of the antigen presentation complex 1, clearly elevated. This is interferon signaling 101, LAG3, a marker of T-cell activation, also strongly elevated. And then many of your favorite pathogenic cytokines, also elevated. TNF-alpha, IL-6 are elevated in Down syndrome, again with a range. More so in those that have a high interferon score. So these are the levels of TNF-alpha on a log 2 scale versus the interferon scores. The higher your interferon score, the stronger elevation of TNF-alpha and IL-6 that these individuals experience. Naturally, we follow this up with deep immune mapping. Now, many others have also done this. The title of this paper says it all. Global immune remodeling with hypersensitivity to interferon signaling. It is hard to find an aspect of the immune system that is not different in Down syndrome. Cell types may be elevated, depleted, in different states of activation. Let me show you just a couple of figures from this paper. This is site of data, mass cytometry. One of the antibodies in the panel recognizes cell surface expression of interferon alpha receptor 1 encoded on chromosome 21. There are 100 immune cell types here, ranked by expression of IFNR1. In green, trisomy 21. Always overexpression in stem and progenitor cells, monocytes, dendritic cells, ILCs, B cells, T cells. Green, always to the right of gray. In every cell type, these receptors are overexpressed. So the entire immune system of a person with Down syndrome is supercharged with these receptors. So perhaps not surprisingly, they are hypersensitive to interferon stimulation. In this experiment, we took the blood, spiking a little bit of interferon alpha in this case, and measured then by mass cytometry phosphostat epitopes, phosphostat 1, stat 4, stat 2. In black, this is how you and I do interferon signaling. We go from a resting state to an induced state. In green, this is how people with Down syndrome do it. Sometimes they start at a higher baseline, but then they always overshoot. They always exaggerate when doing their interferon responses. And of course, you would agree with me, this is not a good thing. This is too much of a good thing. Massive immune remodeling. This is a Disney plot of the mass cytometry data. Here, we're color coding by the effector trisomy 21. There's some blue, there's some red, some things are high, some things are low. And here, we're color coding by correlation with interferon score. And these two Disney plots in the center and the right are very similar. For example, number 8, naive CD8 cells depleted in Down syndrome, more so if your interferon scores are high. Number 6, your effector memory CD8 cells elevated in Down syndrome, more so if you have high interferon scores. This is another way of looking at it. This plot is showing the log 2-fold changes in trisomy versus controls versus log 2-fold changes per unit of change with interferon score, and you have a 45-degree angle line with a good raw value and p-value. Again, the immune changes are stronger, more profound, if the interferon score picked up by the transcriptome is more elevated. Effector memory cells are elevated in Down syndrome, more so with high interferon scores, but you see depletion of the naive subsets, of course, more so with elevated interferon scores. We follow this up with a plasma metabolomics experiment, and the top signature in the title of the paper, activation of the kynurenine pathway driven by these interferon receptors. So the kynurenine pathway, you may know this, is a pathway of tryptophan catabolism that is induced by interferon signaling through upregulation of the rate-limiting enzyme IDO1. And kynurenine can become this very toxic compound, quinolinic acid, that if it gets to your brain, it can cause neurotoxicity. So here's the volcano plot of the metabolomics. The most significantly elevated metabolite in this metabolomic experiment, quinolinic acid. There you see kynurenine, both of them clearly elevated. Again, this is interferon signaling 101. We became very interested in this. Again, quinolinic acid is known as the inescapable neurotoxic. If it gets into your brain, it will bind to NMDA receptors, induce excitatory toxicity. It will start killing neurons. We know memantine, the drug approved for Alzheimer's disease, counteracts quinolinic acid toxicity. It has been tested in animal models of Down syndrome. There have even been clinical trials for memantine in Down syndrome. It's also a potent convulsant. We know that people with Down syndrome have higher frequency of seizure disorders. So there are some skin fibroblasts. This can be seen in any cell that has type 1 interferon. These are 3 cell lines from controls, 3 from trisomy 21, a baseline, and the induction with interferon alpha. This is how you and I induce IDO1. This is how people with Down syndrome do it. Again, they over-induce these ISGs. If you look in the blood, IDO1 mRNA is elevated. And then if you look in the blood, the amount of kynurenine being made tracks 1-to-1 with the amount of interferon signaling, as shown here by this IP10 CXCL10 correlation plot. Okay, so I'm going to pause here. I could keep going. There are many more papers now by us and others. The point is made, interferon signaling is hyperactive in Down syndrome. So what? Is this relevant to the clinical developmental presentation of Down syndrome? Could we understand Down syndrome in part as an interferonopathy? So we've done some interesting animal experiments. I want to share with you one that we published in 2023 in Nature Genetics, where we show that triplication of the interferon receptor cluster contributes to multiple hallmarks of Down syndrome in these animal models. There was evidence in the literature that these mouse models of Down syndrome have elevated interferon signaling. So what we did here, we used CRISPR technology to correct the copy number of only these 4 genes. So we landed a CRISPR construct on each end of the cluster, and then the genome sequencing shows you, boom, the dip in the copies. And the RNA-seq confirms that now those animals that used to overexpress the interferon receptors, now we can normalize expression of the receptors while preserving overexpression of all these other genes that are triplicated in this mouse model. So this is amazing molecular genetics. Now we can subtract the effect of triplication of these 4 genes versus triplication of 120 other genes that are triplicated in this mouse model. So if you read the paper, you will find that an extra copy of the 4 receptors contributes to the global dysregulation of gene expression across multiple tissues. It confers a lethal immune hypersensitivity phenotype. These animals do not tolerate a little injection of poly-IC. They waste away and die if you trickle their toll-like receptor signaling. The interferonopathy contributes to the congenital heart malformations, which of course are very common in Down syndrome, contributes to developmental delays and cognitive deficits, and also to the craniofacial abnormalities. One key conclusion from this paper is that the interferonopathy starts in the womb. We can see these interferon signatures in the brain, in the heart, in the lung of those embryos inside the womb of the pregnant female mice. Now, of course, we can do CRISPR in human beings. What else can we do? And out of the many ways in which you could target interferon signaling, we thought that JAK inhibitors would be the most elegant approach. All 3 types of interferon signaling employ JAK1 kinases in combination with TYK2 or JAK2. So any JAK1 inhibitor should do the trick here. And you're familiar with these medicines, short half-life in the body, fully reversible action. Many of them now approved for a number of indications. So our first trial focused on the autoimmune skin condition. Participants needed to have Down syndrome and a co-occurring moderate to severe form of these skin conditions shown here. They're all more common in Down syndrome. Again, about 35% of adults or more have at least one of these. And the protocol called for 4 to 9 months of treatment with the JAK inhibitor tofacitinib that was introduced earlier today. This was funded by NIMS. So we had a main arm of 16 weeks, optional extension arm of 24 weeks for those that didn't get full benefit, molecular analysis, skin assessments, cognitive testing, primary endpoint safety and interference scores, secondary endpoints cytokine scores and improvement in skin pathology, tertiary endpoints looking at the neurotoxic metabolites, autoantibodies, cognition. So most importantly, it is safe to give a JAK inhibitor, at least tofacitinib, to a person with Down syndrome. We ran this trial during the COVID-19 pandemic, 2020 to 2024. 10 of these participants developed COVID-19 infections. None of them was hospitalized. None of them had complications. And if you look here at this chart of adverse events, even the most common adverse events, runny nose, affecting only a fraction of the participants, mostly grade 1, grade 2s. There was a single serious adverse event over 27.7 years of observation. A lady that was taking estrogen-containing contraceptive pills developed thromboembolism, which are also a risk factor of JAK inhibitors. So this was annotated as possibly related to the JAK inhibitor with a confounder that we also had a second medicine. In the picture, this participant recovered favorably, was treated with anticoagulants and did just fine. How about the molecular markers? Well, as advertised, these JAK inhibitors lower the interferon response, take care of the cytokinopathy. In this age range, there's a tenfold increase in interference scores. When participants come up baseline, they are about average for Down syndrome, but then within 2 weeks, as soon as 2 weeks, you can see these interference scores coming down to a range more similar to the general population. We're not even suppressing, we're like bringing almost to the normal level. We're not going any farther below. So I like to say that this is immunomodulation, not immune suppression. If I show you the cytokine scores, or if I show you the kinase metabolites, all the graphs look exactly like this. 2 weeks, sustained for as long as you keep giving the medicine. How about the skin? When we started the trial in 2020, not a single JAK inhibitor was approved in the immunodermatology space. Fast forward to 2025, these JAK inhibitors are the darlings of our colleagues in the dermatology space. We agree. Look at these cases of alopecia areata, a baseline. All of these participants, 80 to 90% of the participants get their hair back when on tofacitinib. Okay. Now we saw other things that were less expected. I'm going to show you a video.
When I want to go to Vicky's office, she is always welcoming and understanding to me. Whenever I need help with an she helps me understand it much better. Hi, it's me. I'm Maya. My fit for today is that we love my long necklace because it's all silver-like. So with this applique thing up top.
Maya, do you know your dad's name? Can you tell me your sisters' names? What have you been talking about?
I had tons of dreams in my future. I wanted to like dance more. I also like to design clothes for a living. I have a job. It's called Wags Consignment. It's like a fashion extravaganza. Like an Ariana Grande approved product. It's definitely lacy, but yet bold, but still very sophisticated.
So that's my friend Maya Yeager, who in her early 20s, she lives here in Colorado, went to college. And then a year later, the family gets a phone call saying you had to come pick up your daughter. She's gone. Catatonic, lost speech, cannot sleep, cannot feed herself, cannot clean herself. This is known as Down syndrome regression disorder. It's a devastating condition that affects a fraction of people with Down syndrome. Catatonia, mutism, depersonalization, loss of ability to perform activities of daily living. And the science is clearly suggesting that at least a subset of these cases of regression are associated with immune dysregulation affecting the central nervous system. And you could think analogously here, something akin autoimmune encephalitis. So Maya and other participants with regression were enrolled in the trial because of their skin conditions. And you saw what happened. I should say not everybody has such a spectacular response, but the effects of those that benefited were so spectacular. And after so many years of these participants being gone and gone, that it made it to the cover of the Washington Post last year on Mother's Day, rightfully so, because it was the moms, Eileen, Linda, Maya's mom, who never stopped asking for questions, who did scientific research themselves, and who connected many of us to start thinking about a potential immune basis for regression. And in fact, Dr. Santoro, shown here, and I connected Dr. Santoro at Children's Hospital LA to launch the first ever clinical trial for Down syndrome regression disorders. This is a collaboration between CHLA, Children's Hospital Colorado, and the Cernic Institute, with all these wonderful colleagues. We're almost done. We're going for 60 participants. There are only 3 or 4 slots left. Tremendous demand for solutions for this community. So what we're doing here, we're getting more ambitious. We're comparing the JAK inhibitor to IVIG versus a psychiatric medicine that doesn't touch the immune system, the benzodiazepine, lorazepam, that treats the catatonia. we're comparing the safety profile, the efficacy profile, and doing a lot of mechanistic investigations, trying to understand more what drives the SRD and then what may explain the response to these various therapies. So in conclusion, I think it's safe to say that interferon hyperactivity could cause many health issues in this population, autoimmune disorders, obviously, severe complications from lung infections, perhaps some of the neurological phenotypes. Clearly, research into the immune system of people with Down syndrome has led to first-in-kind clinical trials. And we're strong believers that restoring immune balance in individuals with Down syndrome could have multidimensional benefit, even perhaps from early development. We like to say that Down syndrome should be understood in part as an interferonopathy. Many outstanding questions. What is the long-term safety profile of JAK inhibition in this population? What are all the possible benefits of immunomodulation beyond obvious immune conditions? How early to start? Is prenatal treatment with JAK inhibitors? Wow, even a thought, right? A possibility. Should everybody with Down syndrome be treated, or should we develop biomarkers of response or benefit of efficacy? A lot of questions that will require a lot of research. This is my last slide. I'll show you the work of probably 100 different individuals. If I put the names here, you wouldn't be able to read them. So I want to restrain myself and acknowledge the program leaders at the Cernic Institute, Kelly, Angela, Matthew, and Lindy, the funding agencies, lots of funding from NIH, but also from our philanthropic partners, many research participants and their families, and many wonderful collaborators and the team at the Global Down Syndrome Foundation. And with that, I hope that, that we have time for questions, comments, and criticisms. Thank you very much.
Fantastic talk, Joaquin. I think everybody got really a tour de force of all of this data, and it's fascinating data for sure. So as we said earlier, feel free to drop your questions in the chat that we can do it, and I invite the other panelists and Scott, who's moderating, to join as well. While I see people drop it in the chat, of course, like the case that was presented initially, the more severe phenotype, which makes some of the usage of a medication like tofa and other JAK inhibitors even more like forefront. I think a lot of us, like in clinical practice, see some patients with Down syndrome that have milder to moderate phenotypes, and you can see the signs of inflammation, but they're not severe enough in some of the discussions, even though you've shown really good data on safety profiles, and we know that for other conditions. But on the milder to moderate phenotypes, not talking about like severe regression, but more like overall inflammation and autoimmunity, if it falls outside, let's say, of the 5 diseases that you were using for your trial, what is the role that you see like right now, or what you do in clinical practice for your patients in terms of use of JAK inhibitors for those?
So your question is the point of our third trial, which we are currently discussing the outcome measures and the endpoints with FDA, where we want to make the trial open to anybody with Down syndrome.
Okay.
Without an obvious immune manifestation, and then make the primary endpoints neurodevelopmental assessments, memory, executive function, visual motor coordination, and also just global health. What is the clinician's global impression of this person? Is the person getting healthier by being on a JAK inhibitor? And we had a good time with the FDA, doing rigorous back and forth. And now the FDA agrees, after seeing the data that I showed you and more, that is reasonable to expect benefit for anybody with Down syndrome. So that trial, hopefully, will be standing up here in early 2026, ages 6 to 22. So I don't have a good answer for you, but because again, we have only used the JAK inhibitor up to this point to people that have a concurrent immune condition. But I hope to have the answer for you maybe in 2 years' time. Yeah.
Okay.
So, Joaquin, can I? I'm going to elaborate on Rebecca Marsh's question. Obviously, you started your study back when, tofacitinib was practically the only drug on the block, but now there are, probably a dozen or more different JAK inhibitors, and we've got, monoclonals directly blocking interferon beta, interferon receptor, interferon gamma receptor. So, is there a thought of keeping things broad or keeping things narrower, or time will tell?
For the time being, with evidence that we have, I think JAK1 inhibitors, and they may have a second target, JAK3 or something else, are the preferred approach. Type 1, 2, and 3 interferon signaling, they all use JAK1. As far as we can tell, the interferonopathy is of a mixed type. In the periphery, in the blood, the interferon scores track mostly with interferon gamma. So you could think that perhaps an anti-interferon gamma strategy may be of benefit. But when you look at it throughout various tissues and in cells, type 1 is also highly elevated. So I feel like the antibodies, right? Or going after the ligands won't get you there. I think that you'll turn down, only parts of the pathway. Now, with all that being said, of course, when you go to JAK inhibitors at the signaling node, you perhaps are maximizing the chances of side effects or strong immunosuppression. Now, so far, as I was highlighting earlier today, we don't see overt immunosuppression. What we see is normalization of all these signals, and not even full normalization. So until further notice, I'm a big proponent of JAK inhibitors.
Awesome. All right, a couple more questions for you. Yasim Kukuk is asking in the chat as well. If what is known in terms of the patient's immune senescence or thymic or T cell exhaustion for these patients?
Yeah. So people with Down syndrome have immunosenescence. Not everything in Down syndrome is immunosenescence, but there is an immunosenescence component. The interferonopathy is there all the time. The interferon scores don't go up with age. We calculated interferon scores from 6 months old to 50 years old. And, they're always high with variability. Now, within that background of a consistent interferonopathy and a consistent autoinflammatory phenotype, there are things that do get exacerbated with age, right? For example, we all lose our B cells over time. People with Down syndrome lose them much faster, right? I like to say this much. A person with Down syndrome age 40 has the number of B cells that a person in the general population age 80, right? So having Down syndrome adds 40 years to the birth certificate of your B cells. And this happens to be also what you see in terms of COVID-19 hospitalization and mortality. Having trisomy 21 makes a 40-year-old with Down syndrome be at risk equivalent to an 80-year-old without Down syndrome. So there's clearly an immunosenescent component, but it's not just that. There's other things going on.
And Randy Cron was asking if you've seen any zoster cases in your patients on JAK inhibitor.
No, not on the first trial, not ever up to this point. And none of the very severe side effects of JAK inhibitors were documented in the first trial, and so far not in the second trial. So that's very reassuring. No gastric perforations,
None of like those side effects.
Yeah.
Nabil is asking if you can comment on the use of anti-IL-6 during HLH in pronounced Down's phenotypes.
IL-6 is elevated in Down syndrome, so it would seem like a reasonable target. However, there's a bunch of other things that are elevated, and I feel like going after IL-6 alone may not take care of the full phenomena. The JAK inhibitor lowers TNF-alpha and to some degree IL-6. So in a way, using the JAK inhibitor is targeting IL-6. And remember that IL-6 also employs JAK1 and JAK2 for signaling. So if you're using a JAK inhibitor, in a way, you're turning down IL-6 signaling as well. So we don't have experience with IL-6 antagonist, in any large numbers that we could do a superiority study. But I remain, again, more enthusiastic about tackling the interferonopathy first and then let the cytokinopathy follow.
So I'm hoping you can comment. Maria Gutierrez sort of wants to talk about lung disease in trisomy 21. And, you're probably aware of there's a systemic GIA-associated lung disease where patients develop a PAP-like phenotype. Patients with interferonopathies are prone to getting a more fibrotic ILD, like in SAVI. And I understand that trisomy 21 patients have like a baseline alveolar simplification. So tell us what kind of things you're seeing in the lungs and what that might have to do with interferon.
Yeah. Everything you said is correct. And we haven't done any lung assessments in the clinical trials. I would say the only lung-related stuff that we've done is watch out for that COVID-19. We recruited our first participant in October 2020, ahead of the peak of deaths by COVID-19 in the USA. And we kind of knew going into it and had to convince the DSMB and the IRB that we knew that calming the immune system was going to be good, right? So we're very happy that despite the fact that 25% of the participants got COVID, none of them had to go to the hospital. Now, we did not do the lung lavage, or we didn't do anything really, or imaging or spirometry to know if their pulmonary function was getting better. But it's an obvious place to look at for sure.
And any pulmonary hypertension as well?
Ooh, so I can tell you, if somebody had rampant pulmonary hypertension, they wouldn't qualify for the trial, right? They wouldn't pass the safety screening. But I can tell you that those with history of pulmonary hypertension have strong interferon signatures. And if you read the pulmonary hypertension literature, there's at least a subset of pulmonary hypertension cases that have a strong inflammatory component. And I had read case reports and case series where when you treat somebody with polycythemia vera and pulmonary hypertension with a JAK inhibitor, the pulmonary hypertension gets better too, right? I think that there are nuggets in the literature to suggest that the pulmonary hypertension phenotype, and to clarify, this is way more common in Down syndrome and is one of the most dangerous co-occurring conditions in Down syndrome. There's reason to believe that calming the immune system may help with the PH phenotype.
And do you notice in some of our inborn areas of immunity with immunodysregulation where we use JAK inhibitors, sometimes they're working great, and then suddenly you have a drop-off in their efficiency, which I'm not sure we can fully explain yet. Have you seen that in patients with trisomy 21 as well?
We haven't. We have follow-up up to 40 weeks. That's less than a year. The immune markers remain low. What we see in the regression scenario, we see flares, ebbs and flows like you would expect for any autoimmune condition. And our neuroimmunologists crank up tofacitinib to 10 mg twice a day for a month or two and then come down. So we haven't seen a total fade out of the response, but what we see is that you have to adjust the dose in regression to get it.
But not like cover response.
And then I guess it goes without saying that if you stop taking the JAK inhibitor, the alopecia comes back or the regression comes back. There's no. I was interested in the case that was presented today that at least for a few months there was a resetting of the immune system. That's good, but I don't think that will be always the case.
Perfect.
Good moderator's choice. So in some of the endophrenopathies, we see that there's a high basal state, but a loss of reactivity. But that's not really what you see in trisomy 21. And so I wonder, molecularly, or do you have any hypotheses about why that might be?
Yeah, there's no desensitization that we can tell of in Down syndrome. We gotten, this blood of a 30-year-old with Down syndrome that has the interferonopathy for decades, and we put interferon alpha, interferon gamma, and they go overboard. Now, of course, you also see the negative feedback in place, right? You see ISG 15, the ISGs that are, you see IL-10 elevated. So the negative feedback loop is there and is crank up and is trying to shut down the interferonopathy, right? But the receptor is still there. So it may be that people with Down syndrome go through cycles, ebbs and flows of high and low interferon signaling because of the negative feedback loop. But as a rule, I don't think there is desensitization, long-term desensitization. The one thing though that I think the negative feedback loop, IL-10 and other things come into the picture, it has to do with lung immunity. You may know this, that interferon signaling suppresses antibacterial defenses in the lung, right? And that's why, after a good viral pandemic, you get a bacterial pandemic, right? And the deaths from the Spanish flu were not because of the virus, were because of the bacteria that follow. So I think that the fact that people with Down syndrome have this high risk of bacterial pneumonia in their adult life, is the number one killer before Alzheimer's. I think that's part of the interferonopathy, is that suppression through IL-10 and other mechanisms of bacterial autoimmunity defenses, antibacterial defenses.
And is there bacterial pneumonia also of the sort of staph variety that seems to be, post flu at least?
Yeah, absolutely.
Wow, I didn't know that.
Would that prompt you that those patients could potentially benefit from antibiotic prophylaxis as well?
Absolutely. I think that, the Spanish flu educated us for COVID-19, and everybody with COVID-19 was getting antibiotics up front to prevent that second hit, right? So we're very curious about, we don't even know how to run this study, but can we help adults with Down syndrome to launch better pneumonia defenses by suppressing the interferon signaling? It seems, counterintuitive, but remember, JAK inhibitors are approved for COVID-19, right? So I think we need to be very open-minded here about the benefits of keeping that interferon response within a reasonable range, not any higher. There may be all kinds of benefits.
And Ivana is asking in the chat if you've compared interferon signature in Down syndrome relative to patients with Savia or Aicardi-Goutieres syndrome.
We haven't. My prediction is that Savia and AGS will be type 1. Right? That's a type 1 interferonopathy. Whereas we can tell our Down syndrome is of a mixed type with a strong type 2 component.
Amazing. I think we could be here for hours because this is really fascinating and great data for sure. At the sake of time, because we're reaching the hour, just want to thank everybody. Thank you, Dr. Espinosa. Thank you, everybody. Thank you, Jonathan, for the participation. I think it was a really, really great talk and discussion. On our CIS end, we're going to be off of the webinar for the month of December, but we'll be back in January, so stay tuned for the announcements. Scott, I don't know if you want to.
No, thanks. I echo that. Thanks, Dr. Espinosa. Thanks, Dr. Lee and Dr. Pahalik. Thanks, everybody, for tuning in. And this will be available on the CIS YouTube channel.
Absolutely. Everybody has a wonderful day. Thank you.
Bye-bye. Thank you guys again for the invitation.
Thank you.